Good morning. What we're talking about today is pediatric sepsis SMG 604. Some of the things that's going to be covered is statistics, pathophysiology, SIRS, MODS, what to look for, and your treatment. Pediatric sepsis, just a general overview of some statistics. 6 million children die every year worldwide from sepsis. In the United States, more than 750 cases of adult and pediatric sepsis are diagnosed every year. In the last decade, of the 75,000 severe sepsis cases, the mortality rate is greater than 10%. From 1999 to 2005, severe sepsis in newborns more than doubled in the United States. From 4.25 to 9.7 per thousand births. Infant boys have a 15% higher rate for sepsis than girls. So let's talk about the pathophysiology. Remember your ABCs. If the patient has acquired infection, blood vessel problems, and circulatory collapse, we're looking for sepsis. Pathophysiology continued. Your infection is introduced. It can be bacterial, viral, parasitic, or fungal. Once they enter the body, they will start the reproduction process. Gram-negative bacteria have endotoxins, lipopolysaccharide layer on the cell wall that are extremely irritating to the immune system. The gram-positive bacteria, on the other hand, may produce endotoxins, which are classified as superantigens due to their ability to overstimulate white blood cells. The immune system's first responders are the macrophages. Macrophages attempt to consume or destroy the pathogens. During the first response, the macrophages produce cytokinins. These cytokinine cells signal proteins that will activate an additional immune response. The cytokinins are triggered inflammation in the area of infection. The blood vessels dilate, the capillaries leak, and cause tissue edema. This allows for greater flow of the immune responders to the affected area to attack the pathogens. That's how our body is working to fight the infection. However, later on, it causes problems. Neutrophils are released to fight, and other immune factors also respond to fight with the pathogens. Harm can happen to good body tissue, resulting in increased blood vessel leakage. Even more release of cytokinins increase temperature to the affected area, and that cues the hypothalamus to reset the patient's temperature, producing a fever. Temperature increase will help slow pathogen replication and improve your immune system activation. Chemicals trigger the clotting cascade, increased clotting, and decreased fibrinolysis. Every one of these factors responses have intrinsic limits. Antagonist factors help to restore balance when danger is past. That is how your body works to fight infection. But what happens when the cytokinins travel beyond the area of initial infection? When the cytokinins travel beyond the initial infection area, a domino effect happens. The inflammation increases, increased immune response, increased coagulation, and all of these allow infection to travel throughout the body because of the dilated blood vessels and the damaged and leaking vessels due to the overwhelming infection. This is where we come into sepsis. Systemic inflammatory response syndrome. The causes can be trauma, pancreatitis, pulmonary edema, anaphylaxis, and finally infection, which is what we're talking about today. When this systemic inflammatory response is caused by infection, it is called sepsis. As cytokinins continue to spread throughout the body, we will see vasodilation, so it causes distributive shock, leaking blood vessels, hypovolemic shock, and clots, which is causing obstructive shock. We have a pediatric modified sepsis criteria. Consider a patient septic if any two of the following are met. The body temperature is greater than 100.4, altered mental status, tachycardia or heart rate greater than 90 beats per minute, or if it's high for the age range, They have tachypnea, respiratory rate greater than 20 or adjust according to age, serum glucose less than 120 or lactate greater than 4. Remember with these pediatric people though, their lactate does not always change. If we don't stop it there, what's next is septic shock with multi-organ dysfunction syndrome. At this point, the patient can no longer compensate without assistance. The organ dysfunction begins. This is septic shock, and early on, it may respond well to treatment, such as fluid boluses. You're looking at a fluid bolus of 20 mils per kilo. Once 2 or more organ systems are impacted, it is considered MODS or multi-organ dysfunction syndrome. Your clinical definition is a systolic less than 90, a MAP of less than 60, ARDS, end-tidal less than 32, glucose less than 120, and again, a lactate greater than 4. However, these pediatric patients may have normal lactate levels despite their severe sepsis or shock. Early onset neonatal sepsis, and I threw this in here. I know that our neonatal team usually takes these guys, but it was some good information. Early onset neonatal sepsis is within the first 72 hours of birth. The late onset neonatal sepsis is greater than 72 hours to 30 days after birth. The risk factors for these little people are premature birth, rupture of membranes that's greater than 24 hours before delivery, or if the mother has an untreated infection at the time of delivery, including group B strep, syphilis, herpes, rubella, cytomegalovirus, or toxoplasmosis. Children less than 90 days old are at an increased risk due to underdeveloped immune systems and the inability to make antibodies. I thought I'd throw this in here. Of course, we've got guidelines for what the criteria is for sepsis, but make sure you're adjusting according to age and what their normal vital signs should be. Do not wait on these patients. Be cautious in these pediatric patients that you're going in, because if the patient is tachycardic, don't wait for them to become hypotensive to intervene with fluid boluses. Pediatric patients with sepsis and hypotension are pre-arrest patients. They are going to go bad, and they are going to go bad quick on you. Remember your CAB, circulation. If it is not already done, you need to start an IV or get an IO access. If an IV is not necessary, these little kids are going to be vasodilated, leaking fluids. Their veins are not working well, so if you need to go to an IO, do that. Start a fluid bolus. You're going to do 20 mils per kil over 5 to 10 minutes and repeat times 3. Your goal is 60 mils per kilo in the first hour if this kid is not responding. Airway considerations, you want to consider early intubation in fluid refractory shock, or breathing. You need to intubate any kid with a compromised airway. Remember that on these little kiddos, infants or neonates with severe sepsis may require early intubation. However, intubation and mechanical ventilation increases the intrathoracic pressure, which reduces venous return and leads to worsening shock. You've got to get the fluids on board and start that fluid resuscitation before you intubate these kiddos. Your treatment is going to be early antibiotic therapy is imperative. If you question sepsis at all and this doctor has not started antibiotics before you're leaving that facility, ask him for it. Ask if there's some way you can get an antibiotic started. Rule of thumb, it's just Rocephin, 50 milligrams per kilo with a max dose of 1 gram. Suspect sepsis with any unknown infection. Fluid refractory shock. These kids are not improving with your fluids. If no improvements within an hour of aggressive fluid, so you're looking at that 60 mLs per kilo boluses, you need to consider ionotropes. If you walk in and your kid is already past that, go ahead and start your ionotropes earlier, but just rule of thumb, you want to give that 60 mils in the first hour. And you need to consider your cold shock versus your warm shock, because that is going to affect what drug you're going to be giving. Your cold shock, these are your signs and symptoms. You've got a high systemic vascular resistance, so you're going to have a low cardiac output, you're going to have cold extremities, delayed capillary refill, weak and feeble pulses, hypotension, and a narrow pulse pressure. If these kids are in cold shock, you are in trouble. Intervene immediately. For cold shock, we're going to use epinephrine. We're going to go ahead and use the 0.1 to 1 milligram per kilo per minute, and I've put your mixing concentrations on there. So you'll mix 1 per 250 for a concentration of 4. Your warm shock. All shock is bad, but this isn't quite as bad as your cold shock, but we still need to be intervening, because you will end up in big trouble with these little kiddos, because they have probably already compensated as long as they possibly can. The warm shock, they're going to be warm flushed peripheries, capillary refill less than 2 seconds, bounding pulses, tachycardia, relatively maintained blood pressures, and widened pulse pressure. With these guys, you're going to go ahead and start with the norepi, and it's 0.1 to 2 mics per kilogram per minute. You're going to mix 4 milligrams and 250 of D5. Adjunct treatment that we need to be thinking about. We need to be checking these kids' glucoses, and we need to make sure that they're staying steady. If you need to start D10 on these kiddos to keep your sugar up, they are using a lot of energy just fighting infection. Remember that hypo or hypoglycemia are associated with worsening outcomes. They have increased morbidity, mortality. Hydrocortisone is also another adjunct treatment. You're going to give 5 milligrams, 2 milligrams per kilo, with an infusion of 50 milligrams over 24 hours. So their total over the next 24 hours is going to be 50 milligrams. Your goals of therapy are a normal mental status, heart rate normalizing for the age, your capillary refill coming back down to less than 2 seconds, at normal pulse quality, no difference in central or peripheral pulses, warm extremities, blood pressure is normal for age, and you want to make sure that you're getting that urine output greater than 1 mil per kilogram per hour. Make sure those little people's kidneys are still perfusing. And if you do have a central venous pressure line, you want it greater than 8 millimeters of mercury. Thank you guys for attending today. We appreciate you continuing your education with Apollo. Want you to have a blessed day. And if you have any questions, just in case you don't know, this is Dondi, and feel free to contact me if you don't have my number. I'm sure somebody that you know does. Just get a hold of me. Thanks, and have a great day.